Oh, hi everybody. We're back. The Generalist CCFP 105 Topics Podcast. I'm still Caleb Dusdall, and this episode is amazing. Combination episode, both skin disorders and rashes, written by Lily Shu and peer-reviewed by Dr. Mahmoud Adrawis, who is a skin-focused family physician in Bath, Ontario.
Hi everyone, I'm Lily Zhu. I'm a new graduate from Queen's Family Medicine. I just passed my exam, so I really hope this episode helps all of the listeners. We can jump right in.
Woo!
Yay!
Objectives 1 and 7 for rash and 1 and 4 for skin disorders. In a patient with a new rash, take a focused history and do an appropriate skin examination.
So we start by getting the full story and examining every inch, yes, from the scalp to the soles of the feet. Missing a spot might mean missing a cause.
So this includes checking from head to toe, checking the scalp, the back of the neck, the oral cavity, which we often don't look at, intertriginous areas, so anywhere where skin meets skin, like the axilla, the skin folds between the digits, the nails, look at the nails, look at the perineum, look at the bottom of their feet, and look at all the other mucocutaneous areas that you may be able to think of.
So some key details to ask about here.
Have they had similar issues like this before, and how did they treat them?
Were there any investigations that were done in the past?
Any recent contacts, travel, exposures to irritants or allergens?
Any medications that are on? So common culprits for medication-erupted skin rashes include antibiotics, NSAIDs, and anti-epileptics.
Oh man, people get so freaked out about anti-epileptic rashes.
Oh, really?
Yeah. Is there any family history of skin conditions that might lead you to where you want to go?
Any associated symptoms like pain, itching, fever, or aches.
Nice. That's super thorough. And when dealing with a patient who's got a stubborn or recurring rash, there's a few things that we need to dig into.
So we need to ask them if they're sticking to their treatment plan. Are they doing their prescribed regimens or maybe experimenting with some new home remedies? Sometimes people read stuff on the internet and it's really hard to stick with some prescribed regimens that we give.
What? I've never heard of people trying stuff off the internet. Number 2, are there any confounding medications and treatments? What's the other stuff that they're using? This could be anything from over-the-counter stuff to strange herbal concoctions. People will put anything on their skin if TikTok said to do it. Objective 2 for rash. When assessing a patient with a rash, look for and recognize common patterns to aid your diagnosis.
There are a couple of things we like to use to describe rashes. So for discoid or nummular rashes, you can think that they're circular.
For annular lesions, these are ring-shaped. They include some of the fungal infections or just plain Jane urticarias.
Target lesions are concentric rings, which are often seen in vascular conditions.
Serpiginous lesions, these are snake-like. Think of things like larvae migrans and scabies.
Erythroderma is a dermatologic emergency that includes total redness of the skin, and causes can include eczema, psoriasis, drug eruptions, and other rare diseases.
If you see symmetrical distributions of the rash, this could be something systemic like psoriasis, atopic dermatitis, or a viral exanthem.
Asymmetric rashes, on the other hand, often indicate an exogenous cause, like a skin infection.
This is where derm shines, when you can walk in the room and go, oh, that's this.
It's crazy.
Yeah, it's beautiful. Objective 3 for rashes. Use appropriate terminology with respect to the lesion type, its shape, arrangement, and distribution to facilitate communication and documentation.
Proper dermatologic terminology is really necessary for proper documentation and communication between consultants. Pictures of lesions would really be nice if you can include them in your notes, but sometimes when that's not possible, it's really important to communicate exactly what the rash looks like with our words.
So a quick review of that is some of the stuff you might have covered in med school. Macules. These are circumscribed. They change in skin color that is no more than 1 centimeter in size, and they're completely flat. If you can feel it when you run your finger over it, it is not a macule.
Patch is identical to macule, except it's called a patch if the lesion is greater than 1 centimeter in size.
And then plaques are raised lesions of this sort that are more than 1 centimeter in size.
Papules are also palpably raised lesions, but they're less than 1 centimeter in size.
A nodule is a solid, round, or ellipsoid lesion larger than a papule.
Vesicles are clear fluid-filled blisters that are less than 0.5 centimeters in size.
And if they're more than a half a centimeter, we call them bulla.
A pustule is a vesicle containing pus.
Cysts are cavities that contain liquid, they contain solid, or contain semi-solid material, and technically only if they actually have an epidermal surface within them, but you won't know that right away.
Erosions and ulcers are both used to describe defects within the skin surface. However, erosions specify defects confined to the epidermis, while ulcers extend deeper into the dermis.
Scale is the loss of damaged stratum corneum. Get technical now. The skin fragments into layers when it's scratched, such as in psoriasis.
Crusts can appear when there's serum, blood, or purulent exudate that dries on the skin surface. They can appear yellow to green depending on the causative fluid.
Nice. Listen to that 4 times. It'll all stick in your brain by the time you have to write your exam. Rash, objective 4, and skin disorder, objective 5. In an unwell patient presenting with a rash, identify potential life-threatening systemic conditions and initiate treatment or emergent referral.
The first life-threatening systemic condition we'll go over is called Stevens-Johnson syndrome, where less than 10% of skin is involved, or it's called toxic epidermal necrolysis when there's more than 30% of the skin involved.
I always forget this. Stevens-Johnson's less than 10%, toxic epidermal more than 30%. It is a rare immune-mediated reaction. It's most often triggered by drugs in up to 85% of cases, and it often starts anywhere in that 1 to 3 week window after a new drug has been started, or in 15% of cases, an infection is suspected cause.
Some common drug culprits include anticonvulsants, antibiotics, allopurinol, sulfonamides, NSAIDs, and barbiturates.
The pattern is usually a flu-like illness starts first. They get a bit of a fever that can be quite high. They get a sore throat, some rhinorrhea, some cough, and body ache. So I imagine seeing this person, you're thinking, oh yeah, you've got the flu, get out of here. It can progress to sepsis. They can get crazy electrolyte disturbances. They can get multi-organ failure. It can go really bad really quick.
Yeah, and it leads to this sudden onset severe mucosal ulceration. They have painful purpuric macules with blistering and epidermal sloughing. So if you're touching their skin, suddenly it starts to come off.
Yeah. Not good. You need to get cooking on this. Treat it aggressively. So patients with SJS or 10 are diagnosed and management is initiated right away. And the quicker you do this, the better off your patient's going to be.
So we can often treat this by treating the underlying trigger, which means stopping the causative drug.
Treating any infections that are suspected with fluid resuscitation and wound management.
We can manage these patients often in an ICU or a burn unit.
And can get started often on systemic glucocorticoids because you got to tamp down their immune system. It's going crazy.
The next life-threatening condition that we'll talk about is something that everyone's heard about from the media. Is necrolizing soft tissue infections. There's so many Grey's Anatomy episodes about this.
Is there? I didn't know that.
It's dramatic.
It's true because it has a very high mortality rate, somewhere north of 20% depending on the circumstances.
Initial signs of illness include diffuse erythema, swelling, warmth, and tenderness out of proportion with the presentation.
The late findings are going to be things like crepitus in the area, suggesting there's air underneath. Big bulla. Most commonly with this, I've seen hemorrhagic bulla. If you see that, you should be concerned. Skin necrosis and loss of sensation to the area affected.
And for these people, you really want to treat them quite aggressively, taking them immediately to the ICU or the OR for surgical debridement and giving them broad spectrum antibiotics.
Yep. Next deadly skin condition is meningococcal infection.
So this often involves a petechial rash over the trunk, lower body, and mucous membranes, especially if they have anything in their oral or ocular cavities.
And this is a common one that you see reported as being missed initially as well, because they'll just kind of look normal, kind of sick, and then the petechial rash makes you more excited. All right, another one for derm, potentially life-threatening, is burns, whether that's chemical or non-chemical.
In the acute stage, we need to start with the fluid resuscitation. And often we use the modified Brooke formula. It's calculated by 2 mils times the percentage BSA that's affected by the burn times the kilograms for Ringer's lactate. And we'll give the half in the first 8 hours and then half in the next 16 hours.
I didn't know the Brooke formula. Does it differ from Parkland's?
Yeah, the modified Brooke formula, instead of the 4 mils, it's the 2 mils.
Oh, okay.
I think it's supposed to be more effective so you don't overload them.
Okay. Like Parkland's, we've been unofficially backing off on 4 per percent as well. Interesting. Cool. I have to read up on this. Yeah, and so I mean, it's probably worthwhile at this point too to go review your body percentages. If you get funny little patches, just use the palm of the hand, and that's about 1%, so you can help add things up. But otherwise, you use the rule of nines for everything, and it'll seem like a crazy amount of fluid when you finish your calculations, but it's true. Often you've gotten to the right answer. It's just a lot. And then after you've got that fluid cooking, you're going to employ wound management principles and enable to keep the wound moist for better healing. If it's plastics that manages your burn patients in follow-up, that's them. And you've got a bunch of reasons for referral for burns as well. Circumferential, anything facial, anything to the genitals, or often to the hands as well. Skin disorders, objective 2. In a patient presenting with a skin lesion, distinguish benign from serious pathology by physical exam and appropriate investigations.
To distinguish malignant from benign lesions, a common rule for physical exam is the ABCD rule.
A being asymmetry.
B for border, particularly if there's an irregular border.
C is for uneven color within the lesion.
D is for diameter greater than 0.5 centimeters.
And E is evolution of lesion. Is it growing? Is it changing over time?
And another general rule of thumb, especially for patients who can't really remember the ABCDE rule, is the ugly duckling rule. So if one lesion looks different from the rest, they should probably get it looked at.
I love it. And just cut that little chunk off. If it's not in their face, it's pretty easy peasy. Skin malignancy is generally divided into 3 primary types that we're going to review now.
The first type is a basal cell carcinoma. It's the most common and most benign skin malignancy.
Classic appearance is nodular basal cell carcinoma. It's raised, it's pearly, it's a white-looking nodule with telangiectasias, these little blood vessels going into it and throughout it. But superficial basal cell carcinoma is actually composed of some red scaling plaques with a thready border.
Diagnosis and treatment consists of a full or partial thickness biopsy, and this includes things like a punch, a curettage, or shave biopsy.
And with any of these, the prognosis is excellent. There's a very low rate of malignancy spreading beyond that area that you're seeing there, and they generally grow pretty slow.
The second kind is a squamous cell carcinoma, and this usually presents as a persistent ulceration, so a non-healing wound with crusting, hyperkeratosis. There's some erythema in sun-exposed areas such as the face, scalp, ears, and legs.
Unlike their friendly cousins, the squamous cell carcinomas do have risk for metastases and commonly can get worse in the immunosuppressed patient.
Treatment of these often involves surgical excision and biopsy.
Worth considering, actinic keratoses, or AKs, is a pre-malignant lesion that can rarely develop into one of these squamous cell carcinomas. This is why you bring these people in every year for cryotherapy or topical therapies like imiquimod or fluorouracil cream. How did I do?
Fluorouracil?
Fluorouracil?
Yeah, close. The most important big bad, of course, not to miss, is melanoma, and it's diagnosed with a full thickness excisional biopsy, often with 0.5 to 2 centimeter safety margin, depending on the original Breslow thickness. So to stage it.
And the prognosis for it is dependent on that Breslow thickness. There's a high potential of metastases with these. If you've ever seen malignant melanoma, you want to avoid it at all costs. It sucks.
Our job as family doctors is to have early recognition of this melanoma because it greatly increases their chances of survival. And patients with a personal history of melanoma should have a complete skin exam done by their family doctor or their dermatologist regularly because they're at higher risk of developing a second melanoma. In addition, this exam includes a lymph node examination. So go beyond just the skin, guys.
Nice. Next up is cutaneous T-cell lymphoma, otherwise known as mycosis fungoides.
This occurs when there is lymphocytic infiltration progressively over many years, and this can present as the first complaint or after lymphoma diagnosis.
Often it's going to start with pruritus. They're going to be itchy. They're going to develop oval patches, thickened plaques, and then eventually skin tumors.
The next thing is pemphigus, and this is not to be confused with the more common and less severe pemphigoid blistering disease, such as bullous pemphigoid.
Pemphigus is a group of life-threatening autoimmune blistering and erosive diseases that affect mucocutaneous sites and cutaneous sites.
And treatment of this involves systemic steroids and then long-term immunosuppression, typically with something like azathioprine or mycophenolate. Wound dressings are also very important to avoid infection.
Rash, objective 5, and skin disorder, objectives 3 and 6. In a patient with an undiagnosed rash, consider a systemic disorder, investigate it appropriately, and pursue further investigations or refer as indicated regardless of your negative results.
Some systemic disorders that we'll consider here, listed under objectives, include Wagner's granulomatosis. It's a disease involving small to medium vessel necrotizing vasculitis, and it presents as purpura of the lower extremities, focal necrosis, and ulcerations.
Also consider systemic lupus erythematous. It's always lupus.
You stash your drugs in a lupus textbook. It's never lupus.
This is a group of diverse and persistent autoimmune inflammatory diseases.
The typical acute reaction that we associate with SLE presents as a classic malar or butterfly rash that resolves without scarring and usually appears after sun exposure. It's mistaken for a sunburn often.
It also presents with bullous or maculopapular lesions, mucosal erosions or ulcerations, photosensitivity as discussed before, and diffuse hair loss can come along with it.
On the other hand, subacute or chronic cutaneous lupus are often confined to only the skin without any symptoms of systemic lupus.
Subacute is going to resemble psoriasis with flat, scaly patches.
And chronic might lead to discoid, indurated hyperpigmented plaques above the neck.
Is that what Seal had?
But did you know that when it snows, my eyes become a lot, and the light that you shine can...
Next up, diabetes. This can manifest some funny cutaneous lesions, including acanthosis nigrans and diabetic dermopathy. These are light brown, oval, scaly patches over the pretibial area, so the shins.
Regular examination of these high-risk patients is very important, and these patients include people with diabetes, peripheral vascular disease, or those who are bed or chair-bound because they're at very high risk of skin ulcers.
In these high-risk patients, minor skin lesions need to be treated aggressively. They need regular wound care. They need antibiotics if it appears infected, because you don't want to form chronic wounds that is going to need surgery in the future.
Another systemic disease to consider with cutaneous manifestations is celiac disease, and they can present with something called dermatitis herpetiformis.
I always forget about this. On the extensors, they can get a pruritic papulovesicular rash, kind of nonspecific, right?
Yeah, and we can confirm this by doing a biopsy. They can also present with some recurrent aphthous stomatitis, which is a fancy word for mouth ulcers.
Next up is drug reactions. These are going to appear on the skin as well. They're usually an immunological response, and they often occur following antibiotics.
So these rashes are usually an exanthemus drug reaction. They look maculopapular, widespread, and they're symmetrical. And they can appear from within a few days to up to 3 weeks of starting a drug.
The fixed drug eruption can be well circumscribed inflammatory lesions. They develop in the same area after each ingestion of the offending agent within 30 minutes to a few hours of taking it in. So if that happens, you probably need to believe them that they don't want that drug.
Yeah, and again, some severe drug reactions can lead to the life-threatening SJS TENS syndrome, which we would like to avoid.
SJS, less than 10%, TENS, greater than 30%, and then a magical gray area in the middle. We'll remember that if I say it enough times.
And treatment just involves discontinuation of the responsible drugs with topical steroids and or antihistamines.
Easy peasy. It's derm. Give them steroids. Rash, objective 8. In a patient with an infectious rash, manage risk of contagion and ensure public health bodies are informed when indicated.
There are multiple rashes that are reportable, and this includes chickenpox, which starts on the face and spreads to trunk and extremities. It evolves from papules into vesicles and then into pustules.
For Lyme disease, which we have little to none out west here, but where Lily is in Ontario, it is endemic, and it's often transferred by tick bites.
Yeah, you wouldn't believe the amount of tick bites I see in the Emerge, Caleb.
That have legit potential Lyme?
Yeah. In fact, we pretty much treat all of them prophylactically for Lyme, especially if the tick has been attached for more than 24 hours. This starts as an erythematous macule and evolves into something we recognize as erythema migrans, so the target lesion, and it includes systemic symptoms such as joint pain, fever, and malaise later on.
Based on the time of tick attachment, there is an algorithm for antibiotic treatment, and that'll be linked in the show notes.
The next contagious disease that we have is measles. And this is a macular rash that starts on the face and spreads downward.
And it can also come with an upper respiratory tract infection. This is your CCC situation. And unfortunately, we need to know this one.
Along with measles, there's also rubella that's commonly attached. And this is also macules and papules starting at the forehead. And then the rash actually fades in reverse order as it appeared.
Easy. Objective 6 for rash, Objective 7 for skin disorders. In a patient being treated for a new or persistent skin condition, determine the impact on their personal and social life.
It's very important to realize that although dermatologic disease may not always cause mortality, there's often a lot of morbidity associated, as in with acne or psoriasis.
There's a commonly used scale to quantify the quality of life. That is the Dermatology Life Quality Index for adults suffering from skin disease. That was a mouthful. And I often do this too, like especially when I get adolescents in the clinic, or even in the ER sometimes, if it's low acuity stuff, I say, hey, who's helping you with your acne if I notice a bunch of lesions, because they deserve to get treatment for that. They are aware of it. It's probably eating them up inside, and if you can give them a little bit of appropriate acne treatment and make their life that much better, then this is why we do medicine.
Yeah, I agree. Okay, so that wraps up our episode for today. Thanks for tuning in, and we hope this helps you better understand and manage skin disorders and rashes.
Lily, crushing it. And thanks again to Dr. Andrawis. Thanks for reviewing things. Skin is massive. If anyone wants to start a series on the generalist about skin, I think that would be wonderful. It's not going to be me. This is not my strong suit, but if we have wonderful experts, I think that would be great.
It's okay. You just have to remember to wear sunscreen daily. And that solves half the battles.
Oh man, I'm not even doing that. I'm bad. I'm a bad patient. All right. Thank you so much, Lily. You're a wonder. Should we get out of here?